So the first kind of part of this is to look at the epidemiology or how much of an impact there is with chest pain in the pediatric population. And in general, there's about 650,000 children aged 10 to 21 that are seen annually in the emergency room. Male to female ratio is similar. Within our group in particular, we see about 2,000 outpatient visits per year, and it's the second most common reason for referral. And in the CHOA system, it's about 1,300 ER visits per year. And when they've studied kind of the cost of evaluation, it ended up being around $3,000 and $2,011 per evaluation per patient. So it's a sizable problem.
We have team coverage tonight, beginning with Sports Director Jack Doles, who is.
So I'm going to pause this video for just a second, but this kind of gets to the root of why, it generates so much concern.
It's live in Fenville. Jack.
Susie, they have run the gamut of emotions here in Fenville over the last 18 hours. It started with elation, turned to shock, and now this community grieves. Wes Leonard's last act on this earth was to win a game for his team. Wes Leonard put his team on his shoulders in last night's regular season finale. A win over Bridgman, and they'd finished the regular season with a perfect 20-0 record, with the game tied at 55 in overtime. Leonard got the ball near the top of the key, streaked down the lane, and laid it in for a 57-55 lead. The fans went nuts, but there were 20 seconds left. Fenville got the stop it needed, and the celebration was underway. It looked like a storybook ending to a perfect season. The players lifted Leonard in the air, but shortly after the team huddled up, Leonard collapsed. He was rushed to the Holland Hospital and pronounced dead a little before 11 o'clock.
And so that video kind of, it's a little old now. It's from 2010 about a teenager in the Midwest, kind of highlights, what people are thinking about when their kid comes to them and says they have chest pain, and really why it generates so much concern. Best I can tell from reviewing data available to me is that he had dilated cardiomyopathy. And with regards to the literature on pediatric chest pain, we have a decent amount of things available for our review. And they go back quite a few years. One of the more recent studies kind of looked at, we have larger studies that are retrospective, but in general, prospective studies have been, just very small numbers of patients. So if we look at retrospective studies, on the other hand, including the one done by David Drosner, this was done here in Atlanta and published in 2011, and looked at over 4,300 patients that were seen in the CHOA ER, and of those, less than half of 1% had a heart problem. So that's a statistic I commonly quote to families when I'm seeing them in the office, is kind of, playing the odds just off the bat, we're in pretty good shape. And the causes of chest pain can be quite broad. Some of the musculoskeletal causes are like costochondritis, most people are pretty familiar with, which is an irritation in the junction of the ribs to the sternum. Tietze syndrome is more like a post-viral inflammation of that area that can last for many weeks. You can also have slipping rib syndrome, which is where kind of a rib can slip in and out of joint. That's more common in children with hypermobility. And then pulmonary causes are listed there as well as the common reflux and gastritis, and potentially anxiety related as well. Texidor's twinge or precordial catch is very common also. This is one, the pictures here kind of represent an analogy I use when I'm describing it to parents. But I kind of remind folks that, the way that our chest wall is built is that we have a lining or a membrane on the inside of the chest wall, not on, very much like ribs. If you ever watch them make them on television, they spend a bunch of time peeling that membrane off that's shown in that picture. We're built that same way. So we have that lining on the inside of our chest wall, and then a lining on the surface of the heart and the lungs. And then there's a little bit of juice in there that's designed to let things slide back and forth. And sometimes that can snag. And when it does, it usually hurts pretty bad all of a sudden, in one spot, and you go, put your hand over your chest, take 2 breaths or a few seconds, goes away, and when it's gone, it usually goes away completely, and you're left going, what was that? And it can be kind of alarming when it happens the first time. I remember learning about this in med school, and I'd had it for years and never knew that's what it was, but I kind of learned to ignore it because it wasn't causing me trouble. And this can happen to folks at any age, but it's one of the kind of more common causes of very fleeting chest pain. In a younger child where we can't get clear history, sometimes it can be hard to sort through if they're having pain or actual palpitations. So in a younger child, sometimes that can be a little bit more difficult, but in adolescence, usually just by asking questions, we can tease through that pretty well. Causes of pediatric chest pain also include inflammatory causes, which I think are ones that we worry about, pericarditis and myocarditis, particularly in the setting of COVID. We've seen some myocardial involvement in some of the more severe cases. You can have electrical causes of pain. In general, most people will be able to differentiate, hey, my heart was beating funny rather than it hurting. They'll be able to differentiate that, again, unless they're pretty young. Structural abnormalities can cause pain, like an anomalous coronary or hypertrophic cardiomyopathy, or even more rarely, aortic dissection. And then there are other kind of causes where you can have something acute happen, or perhaps have an undiagnosed dilated cardiomyopathy. So with regards to COVID, addressing that question, there's tons of stuff online if you go and look. In general, it would be unusual to have a primary complaint of chest pain in COVID without associated respiratory symptoms. So if there's no shortness of breath, there's no cough, there's no exertional intolerance, just pain, then it's thought to be less likely to be COVID. So one of the things that, like the video noted, we always worry about, athletes going down suddenly, and this is looking at sudden cardiac death and the potential causes of that. It affects about 600 to 1,000 children per year, most of which are in adolescence. And it's a risk of about 1 in 200,000 athletes. Okay, so really quite rare. But when it does happen, of course, it ends up making the news. This was a patient who was playing basketball. I think this was from 2013 or 2014. And there was another one within the last 5 years of a soccer player in Gwinnett as well. And we'll kind of work through that pie chart. It's kind of one of the most famous charts in pediatric cardiology. But really, that's kind of what we're thinking about when we're evaluating someone who has chest pain with exertion, is how do we exclude these conditions? So one of the ones that makes up the bulk of the problem is hypertrophic cardiomyopathy, which represents 36%. And this gives us a representation of what that condition is. Essentially, it's an abnormal thickening of the muscle of the heart, commonly involving the septum more so than the free wall. And what that does is that when the heart has increased contractility or squeezing harder during exertion, it can lead to a sudden fall in cardiac output because there's not enough room for the heart to fill. Okay. You can see that in these examples. So this is an echocardiogram of a patient, and this is the heart kind of on its side. So this is the left atrium, mitral valve, left ventricle, aortic valve, and the aorta. And you can see these heart walls are quite thick. Normally there would be about 1/3 that thickness. And one of the things that I use this slide to point out is that this condition is progressive with time. So 4 years later, you can now see there's massive thickening of the walls of the heart, whereas before it was, really just moderate. And, that belies kind of one of the problems with trying to evaluate for this condition is that, really, if we just look at one point in time, things could look normal and then it can show up later. And so that's one of the real problems that comes up when people are talking about, gosh, should we do should we just do a screening ultrasound on everyone and look at the heart thickness? Well, you'd have to decide what age do we do that? Do we repeat it? And so that's really what has led some of the national organizations to suggest that a screening echo is probably not going to be cost effective. In looking at the symptoms of hypertrophic cardiomyopathy or findings, exertional chest pain is kind of one of the chief ones, or perhaps dyspnea on exertion. Post-exertional syncope, so someone who is in the midst of running, stops, and then collapses, is one that can be related as well. It's also possible to have vasovagal syncope in that kind of a setting. So really it helps to try to tease out when the symptoms began, if they actually began during exertion or only began after stopping. If there is a cardiac murmur, particularly on standing, so this is the condition, this is why when they do screening evaluations of children for murmurs in a gymnasium full of kids, why they would listen on standing, because if it's present on standing, particularly this will be a harsh murmur at the left lower sternal border that gets louder on standing, then that is abnormal and not consistent with an innocent murmur, and those patients need to be evaluated. Obviously, if there's a family history of heart disease, that should increase our radar. And as I mentioned on the prior slide, this is a progressive disease, so one negative screen in time cannot exclude it. So in a patient who has a family history of this condition, the American Heart Association actually recommends serial screening evaluations. So for example, if a parent has hypertrophic cardiomyopathy, those children are screened every 2 to 3 years during early childhood, and then every 12 to 18 months during adolescence. So the next biggest piece of the pie is coronary anomalies, which represents 19%. This is a patient I took care of during my fellowship, was a 15-year-old guy who, not unlike the story that we heard in the video, was running down the court, put his hand to his chest and collapsed. And there happened to be an ER physician in the stands who came down, checked him, didn't have a pulse, and they got out an AED. And it shocked him and he came back to. And when he was evaluated following this episode, he was found to have this finding on his echo. So this is looking at the aorta. It's analogous to this MRI picture. So here's the aorta, here's the pulmonary artery. And normally the coronary artery would come off here, and then the other one would come off up here. And we see this unusual color signal between the two great vessels. And that is the left coronary artery passing through those two vessels. And this is something that is known to be associated with sudden death. So again, if we look at the bottom image here, the orange shows kind of normal coronary courses. And here we see this abnormal coronary course with a slit-like origin. And that's been known to be associated with increased sudden death. And thankfully, this is one that you can repair. And then after you repair it, then they're okay. So we actually like it when we find this, because if you found it, then you can prevent this problem from happening down the road. The other things that would put you at risk would be if you have a patient who has findings of a connective tissue disorder. So this slide has multiple of the systemic findings of Marfan syndrome. So here's a positive wrist sign, positive thumb sign, pectus excavatum or carinatum. Down slanting palpebral fissures is illustrated in both of these individuals, kind of a long face as well. A bifid uvula is something that is associated with Loeys-Dietz syndrome, which is kind of like Marfan syndrome in that it has aggressive vascular disease, but it's a little bit of a newer condition. And then striae are also associated with Marfan syndrome, as are flat feet. Patients with this condition, in the table of sudden death, aortic rupture only represented about 5%, and thankfully it's quite rare in childhood. This is another patient that I took care of, also during my fellowship. The family directed me to this video of him after I took care of him. That's him there, the guy who just dunked. So very healthy young man, being highly recruited. There he is dunking again. And, you know, essentially the story is that he was standing in line in the cafeteria and, you know, went down. And so you hear that history and you're like, oh, someone's standing in line, probably just prolonged standing, probably okay. Well, he got checked. And then the next piece of information we have comes from this. And if we look at this, this is actually a tracing from the AED that was used. So here we have Henry County Fire Department. Here's where they connect the electrodes. Here's where the patient is connected. And it's monitoring. And it says shock advised. Here it says charge complete. And it is telling them to deliver the charge, but they have not. So then the charge gets removed. It analyzes again and says shock advised, charge complete, and then thankfully they deliver the shock. So then once they deliver the shock, we can see atrial activity here. Here's a ventricular signal, and then we get a resumption of a normal, well, somewhat normal rhythm at that point. And so that AED saved this patient's life. Interestingly, in his workup, we were not ever able to identify what made him go down in spite of really aggressive testing, but he had an aborted sudden cardiac arrest. So that is a class 1 indication to have an internal defibrillator placed. His family was quite concerned about how this would affect his ability to be recruited for basketball and said, we're not interested in him having a defibrillator. And we said, oh, that's very nice. We're interested in you meeting these people. Their name is DFACS. So then they reconsidered and they said, well, we want a second opinion. And they flew out to Stanford in California. And then when he came back, he had a defibrillator. We'll skip over that. This is another patient. So this is a 17-year-old male who presented to the emergency room with chest pain. And in looking at his EKG, we can see some areas where he has a little bit of ST segment elevation. It's not a ton, to be totally honest, but you see it in a lot of different leads here. And, you know, looking at it, it's kind of flat in this location as well, which is a little bit bothersome. So this patient actually ended up having pericarditis. And if we compare that, a lot of patients can have ST segment elevation in their EKG, but usually it's upsloping like this. And this is something called early repolarization, which is a normal variant. So it's a question that comes up a lot when patients are being evaluated for chest pain in the ER, or if someone gets a EKG in their office, you know, because the machine might read this out as ST segment elevation, but this is a normal variant in otherwise healthy kids. Rather amazingly, the rule that we use is based on a study that was published in 1982 and only had 16 patients, which is like quite astonishing. But essentially it looks at the J point, which is the point right behind the QRS. And if that is less than 25% the height of the T wave, then that's consistent with early repolarization. Oops, sorry. So this is another 17-year-old that I took care of who presented with 2 days of coughing up blood to an outside ER. He was diagnosed with pneumonia and then transferred to Eggleston for admission. This is his initial chest film, which is notable for cardiomegaly. Well, it's not his initial film because he's got a breathing tube. And then diffuse pulmonary infiltrates as well. He actually, when I walked into the room to see him, I think this was like my second or third week on call as a cardiology fellow, and he was panting and leaning forward and just really looked terrible. And they were trying to get him hooked to a monitor, and I'd just walk in and go to feel for a pulse, and he loses his pulse while I was checking. And this is what shows up on his monitor. So wide complex tachyarrhythmia. He was quite ill. We ended up doing CPR on him and ended up having to crash him on the ECMO. His initial blood gas was, you know, not good. So severe combined acidosis. thankfully, with ECMO support, he got better and actually walked out of the hospital about 10 days later, neurologically intact, which was just amazing. This was our patient, so we brought the echo machine down to look at his heart, and this is again left atrium, left ventricle, aorta, and the walls of the left ventricle are not coming together very well. If we look at this is an example of a healthy heart, you can see that these walls are coming together nicely, so there's severely decreased function in this patient. This is another picture looking left atrium, left ventricle, right atrium, right ventricle. You can see the walls just aren't moving much. So that patient had acute fulminant myocarditis. And that's one of those things where, it's kind of like the boogeyman. It is super scary, and it is out there. And so one of the things is, how do we make sure we don't miss this? And so in trying to identify how do these patients present, they've reviewed this, and the things that are super helpful is, yes, many of them had abnormal labs. Those are not necessarily always readily available, but they all had an abnormal EKG with, at a minimum, sinus tachycardia. And kind of the chest x-ray was also particularly useful. So in general, if you have someone who's got a reassuring chest x-ray, a reassuring EKG, it takes the risk of this condition way, 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 way down. And one of the kind of tenets is if a patient has tachycardia out of proportion to whatever else is going on with them, this is one of those things that we should think about. Because, hey, yes, they have a fever, but is their heart rate, way too fast for that? Then, do they have decreased function? And that's actually driving their rate up as well. All right, this is another patient. So let's see, I think this was a 4-month-old who'd had progressive cough and emesis, transferred to the hospital because of pneumonia based on the chest x-ray. Interestingly, buried in the H&P, and I didn't change any of the spelling or mistakes in this, but the father had noted that she had lots of sweating and vomiting with feeds, and the intern on that night had said maybe there's increased cardiac demand given a long-term issue. And so this is a baby that has a condition that belongs on the list of things that can potentially cause a baby to be fussy all the time. So they actually ended up getting an ultrasound of the chest to evaluate for loculated pneumonia, and they noted a small pericardial effusion. So an echo was obtained the following morning and revealed the diagnosis. Interestingly, a BNP, or beta natriuretic peptide, which you can think of as being a CRP of heart disease. So it's relatively sensitive and will go up in the setting of cardiac dysfunction or atrial stretch for any cause. And an upper limit normal value is 100. So 2600 is quite high, and the likelihood of that being a cardiac problem then becomes exceptionally high. So when they did that echo, here again we see a heart that the walls are not contracting very well. This is the left atrium, left ventricle, mitral valve. And this in an infant is something where we say, hey, why would an infant have this? And we go looking to see if they have a condition that's affected their coronary artery. And actually, when I was first year cardiology fellow, I wasn't really good at the echo machine, but I could read EKGs pretty well. And on EKGs, this condition has a classic finding of a Q wave in lead 1 and lead AVL. So anytime someone is asking us to read EKGs on infants, we're always looking at that to say, hey, is there a significant Q wave in lead 1 and AVL? Because this could be associated with something called Al-kappa. And Al-kappa stands for anomalous left coronary artery arising from the pulmonary artery. And essentially the left coronary, instead of coming off the aorta, comes off the pulmonary. And sadly, the clinical condition was first described by a radiologist who identified it in his own child. And this is something that doesn't cause any trouble in utero because the pulmonary resistance is high. And so that drives antegrade flow down the coronary and out to the heart. And the oxygen levels in the right heart and left heart are similar in utero. So it doesn't really cause any problems during development. In fact, the heart would look normal in fetal life. After birth, there's balanced blood flow initially, and then you have lower oxygen, obviously, in the pulmonary artery. And then as the pulmonary vascular resistance falls, then you end up getting a reversal of flow backwards through that coronary artery into the pulmonary artery. So it actually ends up stealing blood flow from the myocardium and spitting it into the pulmonary artery, and you get an infarction. And so these children, when they're being fed, which is, babies exercise, actually are having myocardial ischemia during feeds. And that's what leads them to be poor feeders, very fussy, and have poor weight gain. And eventually they develop cardiac dysfunction from it. And they can develop collaterals in some lucky cases that can feed the blood flow, but this usually shows up in infancy with dilated cardiomyopathy and significant mitral regurgitation. It is one that we can often repair or fix. So depending on when it's identified, if it's identified early, the outcomes can be pretty good. If it's found late, then you try to fix it and hope the heart recovers, but sometimes they need a heart transplant. All right, so moving on to kind of what does our data look like in terms of the children that we evaluate for chest pain. We have a algorithm which at first glance looks really complicated, but essentially what we are looking for is a few key features that can suggest that it's a cardiac problem. So if the onset is acute, we worry about that more. If it's positional, we worry about that more. If it occurs during exercise, so that is the big one. Exertional chest pain is one where we should see them. If there's ongoing fever, then we think about some other conditions. If it's associated with palpitations, that's kind of an easy button. Then we would say, hey, we should evaluate them. Then if they have an abnormal physical exam, then that would be another thing where we think about it. And during our evaluation, when we do an EKG, if the EKG is negative and all of the above is reassuring, then we don't usually pursue any additional workup. One thing that I would say is worth noting is that if you have patients who have connective tissue disease or features, we should really try to be mindful of the things that they're at risk for. This is a patient that I took care of who taught me something. So she's a 15-year-old female with Marfan syndrome. She'd had 2 to 3 weeks of back and chest pain. She said, oh, it's worse when I press on it and worse with deep breaths, which to me is reassuring typically. Usually I think about that being associated with musculoskeletal pain. Comes and goes throughout the day, but has been present every day since it began. And rather curiously, she can remember exactly what she was doing when it started. I think she was standing in line at Disney, and wasn't on a ride or anything, but she can remember the exact moment when it started, which I thought was a little unusual. And then she relayed to me that they were planning to take a trip to, I think, Venezuela the following week. And I said, look, I did an echo to make sure the aorta was okay. I said, look, because you have Marfan syndrome, we should probably do an X-ray, just to make sure. And then sure enough, she had a pretty sizable pneumothorax, which is much easier to see when I highlight it on the film. And so unfortunately, instead of going to Venezuela, she got to go to the hospital. But I would say if they have an underlying connective tissue disorder or something that puts them at risk, we should think about the other things too. So thankfully, she taught me a lesson, which was helpful because then when I saw my other patient who came in a year and a half after that one, it's a 14-year-old female with Loeys-Dietz syndrome who had shortness of breath on exertion for 3 weeks, and she couldn't run a lap in PE anymore. She had seen her pediatrician for this, and they had said, well, let's try albuterol, but it didn't really help. And so then they had come to see me because of the exertional intolerance. And, you know, one thing I would tell you is that, you know, she would say, no, I have no pain at all. Obviously, you can see she'd had a spinal fusion. So in general, if someone's had cardiac surgery or a spinal fusion, I don't trust them to report pain accurately because I think their scale has been skewed by their prior events. So in her case, I said, look, you know, I really think we should do a chest x-ray. I've had someone fool me before. And so then she also had a sizable pneumothorax and had to go to the hospital. And she eventually had to get that upper lobe resected. So what about our data? The last time we kind of pulled this formally, we looked from 2010 to 2012, and we had 5,200 patients. And during the initial evaluation of the data, we had 275, or about 5%, that were abnormal. If we removed a PFO, pectus deformities, and PACs, so those were kind of abnormal test results on either an EKG or echo, then that drops our percentage substantially. And again, just to put this in reference, this ends up being one of the largest retrospective evaluations that's been published. So looking at all of these things, you can see some of these things are things that, you know, might not really be associated with chest pain, like a PFO doesn't cause pain. A small ASD wouldn't cause pain, for example, a PDA wouldn't cause pain, but these were some of the things that we found. And then we also had one each of these following conditions, some of these things that are a little more rare. So someone with myocarditis, someone with atrial flutter, quadricuspid aortic valve. And then what we were left with was in terms of cardiac causes of chest pain, we had 39 out of 5,200 patients, which is about 0.7%. The retrospective study done in Boston showed a ratio of about 1%. The ER study done at CHOA that looked at 4,300 kids had about 0.6%, so this is very consistent. And those things that we actually thought were responsible for chest pain were coronary anomalies, rhythm abnormalities, pericardial effusion, and then a couple of cases of hypertrophic cardiomyopathy. So, and if we look at what we would expect to find based on published prevalence, we found just the right amount of Wolff-Parkinson-White, very similar amount of mitral valve prolapse, only 6 of the expected 10 coronary anomalies, and only 3 of the expected 10 hypertrophic cardiomyopathy. So it's a little bit like us putting our head in a haystack trying to find things. So again, this is kind of walking through our evaluation and who should be seen. So if it's acute onset, positional, or worse with exercise based on history, those things we would say, hey, we should probably evaluate them. If they have associated symptoms of palpitations, syncope, or dyspnea, then we should evaluate them. And then additional symptoms would be kind of if they have extreme fatigue associated with exertion, that one is a hard one, or extreme shortness of breath during exercise, then we should see them. If they have prior medical history that raises their risk, this is the easy button. You know, if someone's had heart surgery and they're in there talking about their chest in any way, we should see them. If there's any kind of family history that's naughty, particularly of cardiomyopathy or aortic dissection, or on exam if they have an unexplained fever. Right now, we have a little bit of trouble with that because of the current clinical policies where we're trying not to see people who have fever or who have had active fever because of infectious concerns. So if you have someone that you're worried about, just reach out to us and then we can kind of sort through that. Obviously, if they have a murmur that you're worried about, a rub or a click, signs of heart failure, then we should evaluate them. So this is another guy I saw, I think this guy was a year and a half ago now, who is a 19-year-old previously healthy guy who I had seen once before for a Marfan evaluation, was a tall, slender Caucasian male presenting with a 2-day history of chest pain that began like he woke up with it. Ow, my chest is hurting. And, interestingly, he reports that he can hear swishing of blood in his heart when he lies down. I said, do you mean you hear it in your ear? No, like I can hear it. And the dad says, yeah, I can hear it too. So listening to him, he has a rub at the left upper sternal border, and when he rolls to the left lateral decubitus position, starts making a strange clicking noise. Dad, during his intake, casually mentions he is the nephew of a prominent state senator. So thankfully, we'd had a normal baseline EKG on him from a couple of years before. And rather interestingly, here in the office, his EKG, is not grossly abnormal, but he's got a huge change in the voltages in his left precordial leads. So if you look at V4 and V5 here, they're very different than the way they looked before. And so that was something that was a little eye-catching. So I echoed him to, prove that his heart was okay, given the EKG change. And then I said, well, by any chance, have you been vaping? He's like, oh yeah, well, I don't do it often, but I did Juul the night before I developed symptoms. So I said, well, I've missed a pneumothorax before, so I sent him for an x-ray, and you probably know where this is going. He has a pneumothorax, so another sizable pneumothorax. Interestingly, he was supposed to go on study abroad to Israel the next week, which was partly what tipped me over to say, hey, let's do an x-ray and make sure before you get on a plane. So he ended up having to have the left upper lobe resected as well. So that's him with a chest tube. I used this story to try to tell people not to vape. The family, said, in any way, do you think this is related to vaping? And I said, absolutely. I don't really have evidence to support that, but there certainly have been reports. And I hate vaping, so I confess to that. But since they're like related to people who can affect policy change, I didn't think it would hurt too much. And then just as a reminder, if you decide to smoke both tobacco and marijuana, it raises the risk of pneumothorax substantially as well. So we are to the end. If you remember nothing else from today's presentation, so the red flags are, the easy button if there's some kind of naughty family history, unexplained death, any kind of cardiomyopathy, and that patient has symptoms, we should evaluate them. If they have chest pain on exertion, we should evaluate them. If they have an abnormal exam, we should evaluate them. If you can push on it and it changes the quality of the pain, so it makes it either better or worse, then I worry much less about those patients. And I'll often tell families that, hey, if you go home and you have it and you can match on it, then and that changes it, then we don't have to stress that that's something naughty. And just to review that chest pain is of course common in children, and cardiac chest pain is rare, but we're trying hard not to miss it. Let's see, any questions?
If you have questions, you can just unmute yourself.
Oh, I saw a hand raised. Maybe it went away. I tried to unmute. Let's see. Self-muted.
Hey, Dr. Iannucci, can you hear me? This is Joyce.
Hey, Joyce. Yeah, I can hear you.
Thank you so much. Hey, everybody, just want to let you know that this is Joyce, your Sibley physician liaison, and I'm going to be emailing Chris your evaluations, and once you complete that, you will get a CME certificate. This was 1.0 CME credits today. So any questions? Can't believe there's not any questions for you, Dr. Iannucci. You did such a great job.
Yeah, that's all right. I used to give out lottery tickets for questions, but it's kind of hard to do that virtually. So
yeah, exactly. So Okay, well, I guess we can end it if there's not any questions. Thank you all so much for joining today. We appreciate it. And thank you, Dr. Iannucci.
No problem.
Okay, I guess we'll exit.